Anesthesiology, I went to Darodia pursuing some short courses, and then I went in the some rural aspect of the Howrah and Hooghly district and tried to practice as pain physician solely without any anesthesiology backup. And for past 3 or 4 months, I did not get even a single patient. No patient came to me.
So we can understand that awareness is also very important, necessary aspect.
Otherwise,
this facility will not be surviving.
And then what will be the economic security?
I understand. Rarik, please.
Good morning, everybody. I am Dr. Arif from Srinagar. My question is that why we are making the pain management synonymous with the needles and the blocks only? Is it a wrong marketing, or we are giving a wrong message? Who is to be blamed? Is it the need of the hour, or it is the marketing strategy? My question to open to all the panelists here, because just the ma'am was talking, mostly she was talking that the curriculum or the training process is just whatever she talked was, I think everything was focused around a needle. But it is very important that all of us, most of the pain physicians are anesthetists. And we have left how to examine a patient, the pathophysiology of the pain, definitely in internship or long back. And after that, we are doing anesthesia. Are we really much enthusiastic about the intervention? So my question to the panelists, who is at fault?
That is Dr. Lokshmi has also tried to answer this question. Suppose one back pain patient is seen by a neurosurgeon, he'll be always thinking of the scalpel. If some physiatrist is seeing a patient, same patient with the back pain, he'll be thinking of some other non-pharmacological modalities. If it is seen by an anesthesiologist who are practicing pain, he'll be thinking of needle. And if we are looking at the, just now Dr. Jain also told the statistics that in the IASP, the 50% of them are from anesthesiology. You can understand, rest 50% is all other specialties. So anesthesiologists are the majority in the pain, not only in India. In India, the statistics might be 90% as apparently what I think. But in the outside also it is more than, in the WIP also the same, 50% are from the anesthesiology. And in my opinion, coming back to your answer to your question, that because the majority of the pain physicians are from anesthesiology, we are always happy with the needle, and definitely the other aspect should not be ignored, cannot be ignored, must not be ignored, particularly the evaluation part. Dr. Jayashree, you want to say something?
Hello. I would like to address this question. Like I mentioned, it's a 12-month or an 18-month program. And the needling part was because, like I started out by saying, safety first. So you don't want the needle in the wrong hands. So what you are taught is not when to put a needle. The emphasis is more on when not to put a needle. So that's where the training goes in. So, and we didn't say anesthesiology and interventional pain. The fellowship is pain management or pain medicine. So there's a lot of evaluation and lot of other aspects of pain that you are taught in the 12 months, not just needling.
Okay, so we are running short of time. Yes. One or two questions we can take from the audience.
Hello. I am Sunita Lavange from Nagpur. Sir, I feel when the patients come to us, it's already too late. So, like the specialists, those who deal with the patients, it's too late when they refer the patients to us. So, the awareness is mandatory amongst them also, because they don't know that pain clinic exists.
So awareness among the other specialties is also very important. Dr. Pradeep Jain, please. One microphone, please, to Dr. Jain.
Hello, I'm Dr. Pradeep Jain from the Nagar Hospital. I just want one thing actually. I also conduct the course, but initially I was just doing this teaching about interventional pain management. But I realized that if we have to broaden the aspect, if we want the pain management to be acknowledged by the MCI, by the university, we should broaden it. Like we must have acute post-operative pain, liver analgesia, cancer pain, and the interventional chronic pain management. If that is done, and the government realizes this thing, then it will be much easier.
So in
than
your
anything
opinion,
else.
acute pain also should be included in the pain curriculum. Okay. Any other from the audience?
It should be a more course.
Thank you. I'm Dr. Amit Thapa. I'm a neurosurgeon by profession and associate professor at Medical College. I'm from Nepal. First of all, I'd like to congratulate the panelists. You are doing a great job. Going to the government or not is the other thing, but changing the attitude of the public sitting here is much more important. What we are doing is rightfully raising a question which is taking the brain of all the people sitting here. Now, when we talk of specialty, it's much more important. The specialty should do something different from what other people in the other specialties are doing. That's first. And second, it should also inculcate the behavior of research to study the pain as such. Now, whatever program that we're talking is only imparting knowledge as to how, when, what to do. But then how to research on the topic, on the specialty which we are dealing, should be imparted as a specialty subject. Now, when I was trained, I had gone through MS training and then I took up my MCH, and I've been trained in the leading institutes in India. Now, what has happened is, during my part of training as MS, I've learned so many things which was not important as a neurosurgeon later. How a neurosurgeon would be helped by doing a lab chole or a pancreatitis patients who are dealing with management pain. So, if in case a person who wants to do pain management later as his career, there should be a pathway where he is not only shown to the different specialties, but also taught about how to conduct a research. What research we are doing in India as well as in Asia are basically practice-based research. We are doing something and we are proliferating that. What we want to do as in Western countries is that we should be research-oriented toward a problem.
Basic research.
Yeah. And
definitely.
second thing is...
this research only can take this, the subject specialty ahead.
And the other point which I like to put forward is, rather than talking of multidisciplinary, we should be talking of interdisciplinary, where pain management should be involved from the very early phase of the patient care. Because as a neurosurgeon, 70% patient of mine are basically coming with pain. And also the output, the surgical output, also depends upon how much patient's pain has been cured. So I'm dealing with the pain throughout. So I cannot just say that I am not pain physician and henceforth I will not see the pain. Now I just wanted to bring in an example here. Say for example, infectious disease. Antibiotics, all doctors are writing after passing MBBS. But now the hospital trends are changing. Whenever we are writing higher antibiotics, we have to consult an infection disease person in the hospital. Now that has served the purpose because they are now coming down the resistant antibiotics lower. Every antibiotic which has been put into restricted protocol have to be informed as to why we are starting it and for what duration are we writing it. So similarly, if the pain management or whatsoever name you can give to this new discipline, if it can be involved at the early phase of the pain management as an interdisciplinary approach, this will not only help the patient but also improve the outcome of the surgeons.
Okay, Kritika, just last question.
What I wanted to say is that just like some surgeries, like hypospadias have been treated by general surgeons, pediatric surgeons, urologists, plastic surgeons. Same way, pain can be treated by everybody, but the good results after a proper training program like ISSP or the Indian Academy of Pain is coming, will make us better at treating pain. So the results will make patients come and prefer anesthetists to other specialities.
Okay, thank you everybody for this very interactive and useful discussion. I understand that discussion, the debates, things will be going on. Continue. Sorry, we have to wind up because other sessions will be delayed. We understand it was a very important and interesting topic. We can continue our discussions outside the hall as well. So, I just want to conclude what we have discussed till now. So, at the beginning, we tried to think that the need of the pain education. In the beginning of the small video, we have tried to show that. A lot of people, even one of our colleagues was also telling that even in the village or in many other cities, they don't know about the pain specialty. Awareness is very important part. Second important part was who should be treating the pain, because there is no specialty in medical science who are not dealing with the pain. So is it the subject of the anesthesiology or is it the subject of anybody else? Should it be a specialty? Should it be a subspecialty or a super specialty? Debates are not going to end here, and I like the comment of Dr. Kaushal that as will be more civilized, there will be speciality, super speciality, subspecialty, and the subject will be gradually developing and standing on its own feet. Thank you very much for your very interactive session. Announcement. One is we are having the feedback counter which will be available till lunch. So any of you can rate a session or any of you can rate a speaker, and based on your feedback, there will be certain the prizes as the best speaker, best session, and there are feedback counter there. And also you can share your views, you can say how we can improve it further, you can say our lacunas, you can say what are the things you liked. We have a counter there, we have a facilities of the video feedback, the feedback on the computer as a star rating, rating of the different specialties. So please come forward and give your inputs, your feedback. And second important aspect is who already have registered, pre-registered candidates, the medical council's accredited certificates has arrived in the counter, so you can have those certificates with the CME 8 points. Who actually attended the workshop, they are going to have the 10.5 hours, and those who are attending only conference, they are going to get 8 CME 8 hours. Thank you very much.